New York State Office of Medicaid Inspector General, Dan Jordan, Inspector General. Good afternoon.
Good afternoon, Chairman Farrell, Chairmanwoman Young, and Chairman Hannan is probably here somewhere. I appreciate the opportunity to discuss the activities and initiatives of the Office of the Medicaid Inspector General as they relate to the 2016-17 executive budget. OMIG is nationally recognized for its commitment to protecting the integrity of New York State's Medicaid program. It has done so through its investigative work and partnerships with other law enforcement agencies, innovative auditing techniques, and proactive outreach and compliance initiatives, all of which have resulted in billions of dollars in cash recoveries and cost savings. As such, OMIG plays a vital role in ensuring that Medicaid recipients throughout the state have access to New York's high-quality, cost-effective health care delivery system. OMIG pursues recoveries where overpayments have been made. Even more important, in my view, are OMIG's efforts to prevent upfront improper costs and billings to the Medicaid program. As we all know, it is far more cost-effective to prevent improper payments in the first place as opposed to chasing dollars after they have been paid. OMIG's cost avoidance initiatives for 2015 delivered savings of more than $1.1 billion through September. These results are on track to exceed 2014's cost avoidance results of $1.8 billion. Each of OMIG's cost avoidance initiatives has its own comprehensive methodology for accurately calculating Medicaid program dollars that are saved. For example, OMIG uses prepayment program edits that we build into the Medicaid billing system that deny improper provider claims. Another area of cost savings is where OMIG has had an intervention with a provider. We will subsequently compare billing patterns prior to the intervention with those after to determine the cost savings attributable to the modifications in the provider's operations that were a result of our involvement. In addition to cost avoidance, identifying and recovering dollars that have actually been paid because of fraud, waste, or abuse in the Medicaid program is a core OMIG function. OMIG's 2015 preliminary audit results through September show more than 1,700 audits initiated and over 725 audits finalized. Cash recoveries for this 9-month period, including audits, third-party liability, and investigations total approximately $250 million. That's cash for the state. That's the state share. Moreover, holding accountable those who intentionally defraud the system is priority number one. To this end, OMIG works independently and in collaboration with partners at all levels, including local, state, and federal law enforcement, provider organizations, and health plan special investigation units, SIUs. These collaborative efforts have become more effective as the healthcare delivery system continues its shift from a predominantly fee-for-service model to a managed care approach. One example of this is OMIG's Managed Care Investigation Unit. The unit investigates complaints received from managed care organizations, MCOs, relating to network provider fraud and works with their SIUs to develop comprehensive investigative plans. OMIG conducts quarterly statewide meetings with all of the SIUs at which it shares recent case referrals from SIUs to identify suspicious trends across plans, coordinate next steps, and provide additional information to enhance program integrity and drive results. OMIG has created a database that is accessible to OMIG investigators consisting of contact information for SIU staff in all managed care plans. Preliminary data for 2015 show that as a result of OMIG's work with the SIUs, referrals from MCOs to OMIG totaled 344, up from 273 referrals in 2014. Also, as part of its managed care focus, OMIG continues to generate results through its reviews of managed long-term care plans, the MLTCs. These MLTC audits on enrollee eligibility for long-term care and whether the plans are meeting the service needs of enrollees based on these plans of care. OMIG has engaged 26 MLTC plans for audit and has reviewed enrollment eligibility criteria and related care plans for more than 4,900 enrollees. In addition, OMIG, in concert with the Department of Health and the Office for the Aging, developed and implemented last year New York's first ever certification process for social adult daycare providers, SADCs. This will play an important role in the state's oversight of managed long-term care organizations and their relationships with the SADCs. Additionally, OMIG has played a critical role in many collaborative law enforcement actions that have resulted in the prosecution of major fraud schemes, enrollment fraud arrests, and drug diversion cases. One example of this resulted in the indictment of 23 defendants who were involved in a $7 million Medicaid fraud scheme in Brooklyn. Last March, OMIG, along with the Brooklyn DA's office, the U.S. Health and Human Services Office of the Inspector General, and New York City Human Resources Administration, announced charges against 9 physicians and 14 other individuals pursuant to a 199-count indictment. The defendants lured homeless people and individuals from low-income areas to medical clinics where they received unnecessary tests in exchange for free shoes. OMIG provided Russian-speaking staff data collection and analysis and intelligence gathering in the course of the investigation. We have also been very involved in drug diversion cases. For example, we assisted the Suffolk County DA's office investigation of Ingrid Gordon Patterson, a nurse practitioner based in Suffolk County. In a one-year period, she wrote more than 1,200 prescriptions of oxycodone for patients who had no medical need for this highly addictive drug. OMIG's assistance included surveillance, data mining services, and reviewing documentation from MCOs. On June 29th, Gordon Patterson was convicted on 5 counts, which included criminal sale of a controlled substance, and on August 25th, she was sentenced to 9 to 19 years in prison. Thus far, 2015 statistics regarding enforcement activity are robust. Preliminary numbers through September indicate that OMIG opened more than 2,700 investigations, completed more than 2,900, and referred 926 cases to law enforcement and other agencies. In addition, during the same 9-month period, OMIG excluded 844 providers from the Medicaid program. This exceeds the 822 provider exclusions for all of 2014. OMIG also places great emphasis on provider outreach and education, particularly focusing on providers having proactive compliance programs that will prevent or, when necessary, detect and address abusive practices. We offer compliance webinars, guidance materials, self-assessment tools, presentations, and a dedicated compliance email address and phone number. OMIG's oversight activities and educational efforts increase provider accountability and contribute to improved quality of care. In 2015, OMIG issued more than 30 compliance-related guidance materials and conducted over 20 educational seminars and webinars. The compliance section of the OMIG website had 36,000 visits to compliance webinars, 25,000 visits to compliance publications, and 40,000 visits to compliance resources and FAQs. Many of our webinars are accredited for legal, accounting, or compliance continuing education credits. In 2016, 206 participants have already received credits, largely because last November we created and posted on our website a 9-part webinar series on New York's mandatory compliance program obligation for providers, as well as a webinar detailing the 2015 compliance program certification process. We at OMIG appreciate this opportunity to speak with you about our Medicaid program integrity activities. And we believe that our provider education and outreach programs, our investigative efforts, and our success in identifying cost savings and recovering inappropriate Medicaid payments play a vital role in preventing and detecting Medicaid fraud and abuse while promoting the delivery of high-quality care to millions of New Yorkers. Thank you. I'm happy to address any questions you may have, although I did tell my wife I'd try to be home for dinner tonight.
Thank you very much. Senator Garbarino.
Thank you very much, Chairman. Quick question. You said over the 2015, 9-month period in 2015,
I'm sorry, I'm getting an echo, and it's my old ears are having trouble.
through investigations in 2015, just that first 9-month period, your department found $250 million in Medicaid fraud. Is that correct?
I'm having trouble hearing you, I'm sorry. Could you switch to another microphone?
Better?
Yeah.
No? In your testimony, you said that there was $250 million in Medicaid fraud that your department found in 2015?
For the first 9 months, we recovered $250 million in cash recoveries. That's state share. The total recoveries would be about twice that.
Okay. Does your office have any estimate about how much additional fraud there is out there, how much we haven't gotten yet?
Again, because it's hard for me to hear, you want me to estimate how much money was stolen that we didn't get?
Yeah. I mean, do you have an idea?
I think that's impossible to do. There are different estimates. Some people say there's 10% fraud in the system. Some people say 30%. But I don't think there's any legitimate way to guess how much money is being stolen. That's one reason why, and you would have seen it emphasized in my statement, in addition to obviously going full steam and trying to get cash recoveries and doing investigations relating to things like drug diversion, one of the things we've been emphasizing more so is cost avoidance, where I gave you some examples. Another example would be where we before a bill is paid, we'll find a third-party insurer through our data mining who should be responsible for that bill and not the state or Medicaid. But I cannot give you with any credibility an accurate guess as to how much money is out there in addition to the money we bring in. If your question is, are we bringing in everything that's being stolen, the answer is no.
Is there a way, I mean, there's a lot in this budget, there's some cuts to some programs that the state pays for under Medicaid. I'm just wondering if, instead of cutting programs that help people, if we gave your office additional funds, I believe your current budget's around 44 million. Is that correct?
I'm still having trouble hearing you. I'm going to come up there and listen to you. It's me. These are all ears.
It's
old ears.
Okay. And you've been speaking too over here.
Maybe just say Mike so the lady can hear you down there.
Well, the question is, instead of cutting certain programs under the budget that are being proposed, would it be better to increase the funding to your office to help with inspectors? Currently, I believe you have a $44 million budget?
No, we're at about, yes. For 15-16, we're at about 55 or just below 55. In the proposed budget, we'd be cut about $2 million. It'd be about a 4.2 cut to, as I recall, I think it's 52.7 million. More than half of that money is federal share. It's about $21 million state share in the proposed budget.
Okay. Will those losses in this year's budget affect recovery?
I can't say that it necessarily will, because there's a few things, directions that we've been going in. One is a better use of technology. One of the things that really impressed me when I came to the agency in late March of last year was the technology that has been put in place in the last couple of years, and the technology that I think we're going to be bringing on board in the next year or two. The kind of data mining that the agency can do is really fantastic now, and it's more a question of how current can we get in terms of the technology out there, rather than how many people necessarily are sitting at desks at the agency. Also, there's a real tropism toward being more efficient in how we conduct our business. The administration has placed a great emphasis on something you've probably heard about, the LEAN program, where agencies now are emulating what private industry does, which is you have what are called Kaizens. You get your folks together for 2-3 days. You break down a particular process, like let's say doing audits. We want to make audits more efficient. For one or two different kinds of audits, we've had lean events where people will spend maybe a couple of days in a room putting up on the walls all the aspects of the audit and looking for the bottlenecks. Why does it take longer to get this out? And some of those kinds of initiatives have had really real-world effective results that have increased our efficiency. So I think in the past, when money was less scarce, there was less incentive for agencies to do that. That has been a real push in this administration. Be more efficient, run your operation like a business, and go toward the best technology you can go to and have people learn how to use it. For example, we've got a wonderful bit of technology called the Provider Audit Documentation System. One of the things I had to learn was about 300 acronyms when I took this job 9 months ago. And it's a wonderful piece of software, and when we work with counties now, when they're doing their own investigations, one of the things we do is teach them how to use it, and we work with them, and it's been a wonderful improvement for the counties and a great help to our relationship. So that's where the challenge is so much, I think, and not so much whether I've got a few more or a few less people.
Do you see the counties are still active, even though their contribution's capped? Are they still an active partner in fighting fraud?
Yes, we have some counties that do a terrific job, and in fact, Onondaga County has been so great that we've been meeting with them to talk to them about what they've been doing because we're interested in some of their techniques. There's more to be done with the county demo projects and other kinds of collaboration, but for example, the counties used to just be able to do transportation, DME, durable medical equipment, and pharmacy, and we've trained them now. And it's quite an effort on the agency part to do that statewide, but we've trained them now where they can also look and audit assisted living plans and also long-term health care. So those efforts, I think, are very good in terms of the results that we get from that collaboration, and where our partnership with the counties has been very rewarding. At least one of the things I'm most proud of with the agency is we work very well with the counties on issues like drug diversion. I mentioned the Suffolk County case just as an example. There have been lots of others, and also what we've been doing, and again sometimes it's in collaboration with the counties. We'll go into pharmacies and we'll look at their inventories and we'll match that against the company records of the wholesaler who's selling them, and we want to see if it matches up. For example, we caught one pharmacist who was buying drugs from people just so he could sell them, almost like some guy in the street, except this was a pharmacy, but they would buy them cheaply. Some of the more dangerous drugs, people who had prescriptions, they would come to him, and he was known as somebody who will buy pills from you and then resell them. And again, that partnership with the county has been very, very helpful in that respect.
I have one final question. I commend your work with the counties. I'm from Suffolk County, so I've seen what you've done. My concern is, though, about the cuts that are in Medicaid now, which you don't have anything to do with, but do you think if your office received more funding, we could get more back in fraud? I'd rather go after the people doing Medicaid fraud than getting rid of spousal refusal or getting rid of, anything, the pharmacy or capping prices that go to pharmacies. So,
look, I think there's nothing wrong with having more resources, obviously, but I think the challenge for state government, and I went through this when I came to Albany six years ago to the State Liquor Authority, where I really saw it there. The challenge with state government is to use what you got effectively before you go around asking for more. And that's what we're in the process of doing, and I think people at the agency are starting to step up and give it their best shot in that way, and then let's see where that takes us. And you and I could have this conversation perhaps a year from now, and we'll see where we are.
Sounds good. Thank you very much.
Okay. I'm going to go back, 'cause I think it was just the mic, but if not, I'll be visiting again.
He may be back. Well, first of all, I'd like to welcome Inspector General Rosen, and I apologize if there are technical difficulties. We'll look into addressing those. I have to say, I also like to welcome you as an honorary member of the state legislature. I think this is a first in New York State history, but I think it shows a lot about you as a take charge kind of person, and That's what we need in the Office of Medicaid Inspector General, so thank you for that. I also want to thank you for your testimony because it did contain details and statistics, which we always appreciate because that cuts down on some of the questioning that we have to do. I may have one or two questions in a moment, but at this time I'd like to turn it over to Senator Hannan.
Yes, thanks, Mr. Medicaid Inspector General. Not like commissioner or anything like that. You raised the question of what you had done in Suffolk on the surveillance and convicted somebody on 5 counts. Wrote more in one year period. You say she wrote more than 1,200 prescriptions.
I'm still having a little bit of trouble, so if you don't mind, I'm going to...
Come on down, dude.
get reelected.
Come on back.
Sit next to the guy with the
You're the
scarf.
last guy I thought I would be able to hear from.
Here, sit right here.
Thank you. Sorry about that. You're good.
It's good. We've actually been having problems up here all day.
I could hear when the other folks were sitting there, I could hear you perfectly.
I think it's something in this one. The question is, this lady was caught writing more than 1,200 prescriptions of OxyContin in a 1 year period. Was this before or after iStop? Because we now have iStop where everybody's controlled substances has to be recorded.
This went back to 13-14, if I recall correctly. Oh, sorry. If I recall correctly, I think this went back to 13-14. But I can tell you, we're taking a real close look, and iStop, I'm not sure, is always working in other situations, and we're really looking at that.
Because that's exactly what we'd want to do. There's been people suggesting we take a better look at iStop. There's the other balance in regard to, do you get it too much of a prosecutorial tool that physicians will try to avoid using entirely? But the point is, it's a rich database that's been reported that it has caught many people doctor shopping, and that has curtailed some prescriptions. So I'd ask to be kept abreast of your look-see into that whole situation.
We'll do that. It's a terrific tool, and we use it very, very much. But for example, I know we're looking at a situation right now where it looks like somebody got a ton of prescriptions from different pharmacists within one plan, and we're looking at whether or not iStop should have prevented that. So that, yeah, we will keep you apprised of our progress. We also do a lot in terms of just to go off on a little bit of a tangent, but I think it's something based on all your comments that you folks are interested in. We also have a restricted recipient program where if somebody does have a history, for the state's protection, for their own protection, they've got to go to one provider for whatever one pharmacy, for example, one primary care, so you don't get somebody basically taking the one prescription and going to 15 pharmacies. So that's been very effective too, and we've beefed that up, I'd say, in the last year or two.
Yeah, it's good to put that on the record. But thank you.
You're welcome. I think I may just stay. That's all right.
Sure, stay. Any more assembly? Okay, Senator Kruger?
Well done. Thank you. Thank you. There we go. It's a follow-up question, I think, to Senator Hannan's. So the state has not yet set up the prescriber's electronic mandate requirement for all prescriptions, but it's scheduled to go in, I think, in March of 2016, so that all prescribing will have to go through an electronic system.
Unless there's a waiver.
Unless there's a waiver, thank you. So I guess it's a twofold question. On the one hand, I hear from mostly doctors in individual practice that they're not really going to be set up to be able to use this system. Perhaps institutional doctors, hospital-based, clinic-based will, but they're concerned they won't be. So I have a concern whether the state is rushing forward. On the other hand, I want to hear your perspective on, is this going to be another tool that helps you make sure that prescriptions are being written appropriately through the Medicaid system?
Yeah, I think this is a very, very important tool. And people have certainly had enough notice that it's coming, so that I don't know, I won't say now what our attitude will be when people make a case for special circumstances and ask for some sort of break. But I know this is very, very important to us, and I think the industry is at a point where I don't think it's it's an overbearing, overly burdensome challenge, again, given the notice that's been out for them to meet this requirement by March. But this will be a very powerful tool, and this will deal with some of those drug diversion issues and some of these opioid issues. It really will. So I think it's very important.
Thank you. And in your testimony, you talk about the enormous amount of money that's saved by actually preventing it from ever going out the wrong door in the first place. And I just want to reemphasize that kind of story doesn't always sort of get told, but that's the critical story, that what you were doing is preventing us from seeing the kind of Medicaid fraud we would otherwise have. Just as a follow-up, so I don't take a third question, is it your experience now that you've moved to OMIG from SLA that the majority of that fraud that you are stopping from ever happening or catching is really on the provider end or the participant end?
Well, I think the bigger dollars are on the provider end. We've had, I mean, we go after recipient cases. And again, for example, we worked last year with law enforcement, and we found a couple in Roslyn Heights who were on Medicaid who lived in a house that was worth about $1.5 million, and were living a very nice lifestyle. So that we do those cases, and we do make recoveries where we can, but the big dollars are at the provider end.
Thank you. Thank you for your work.
Thank you.
Thank you.
Thank you. I did have one question. And so, Inspector General, can you update us on the DSRIP and value-based payment compliance initiatives, and how are things going in working with the Department of Health?
Again, I was having trouble on the microphone, but you basically want to know how we see our role. Mm-hmm. Okay, well, the comment that I enjoyed the most today, as I sat there, and my sciatica was acting up in my left leg. But the thing that totally took my mind off of that was Senator Hannon's comment, and here's a guy who, you know, I know from my 10 months now at the agency, and I've done a ton of reading, I've talked to tons of people in the industry. Here's a guy, nobody's more respected for his knowledge and his understanding of the industry, and he sat here about, was it a couple of days ago or 3-4 hours ago? It seems I've lost track. But he sat here and said, he's still trying to get his arms around value-based payments. And I am too, and I think we all are. And I've been to meetings with the federal authorities like CMS and HHS, and they're still wrestling with it. And one of the challenges that I have to face as the guy who's leading OMIG now is to figure out exactly, you know, what the metrics are and how you enforce the metrics. And that's a real challenge, but obviously it's very, very worthwhile. In the end, the goal is fantastic, but right now it's the holy grail. It's almost mythical. And I watched your hearings months ago, and you were talking about value-based payments, and in terms of trying to get as the new guy, trying to get my arms around something concrete, it was very, very difficult for me to walk away with concrete takeaways. With respect to DSRIP, what we've done is, you know, how do you like looking at my back?
It's cool.
It's all right?
It's all right.
Okay. With respect to DSRIP, our role will change as it unfolds more, but initially what we did was, and again, this was something the agency ramped up to before I came, so it's not that I would take credit for it, but the agency did a really good job about getting out there and explaining to the leads of these networks. You know, you've got these performing provider systems, and then there's a performing provider system lead. And that usually a big hospital, although there are NUCOs that I'm not quite sure what they are. But usually it's a big hospital system, for example. And our folks were very good at getting out and explaining to them what they need to have a good compliance program, good internal controls, good checks and balances for that $7.4 billion that's going to be coming through, not just in their own house, because a lot of them do already as large providers, but also throughout their PPS network, which could have hundreds of providers. And I think the agency did a really good job of that. It also did a lot to check out and verify the attestations that these PPS leads were submitting as to who's in and who's out of their systems. We did a pretty good job on that. And so a lot of those hits that I talked about, one of the things I'm proudest about are those hits on the website, on the compliance and education materials. And one of the biggest areas has been the district-related stuff. We've got a document we put up in tandem with DOH. We've got FAQs on the website. When I was at the SLA, I did record enforcement. We had the highest recoveries ever. A wholesaler in 80 years had never had their license suspended in New York State. There were suspensions, but before I did any of that, I spent at least the first year really making sure I went all over the place, telling people, these are what the rules are, this is where we are now, this is where we're going to be going forward, and everybody had a chance to clean things up if they wanted to, and then we came along with the tough enforcement, and I think there's a real obligation to do that on a regulating agency before you break the door down and come barging in. And that's what we've done with DISRA, so that we try to really help people proactively set themselves up so that the money won't be misspent and everybody embarrassed. Because the concept is fantastic, and if it works, it's going to be wonderful.
Thank you for that frank answer, and I do want to say, I hope your sciatica feels better soon, and hopefully your testimony before us was less painful. So get better, and thank you for joining us.
Have a nice dinner with you.
Okay.
Thank you very much.
Think of us still here.
Yeah, probably.